I'd like to call the meeting to order and welcome Dr. Howard Koh, the Assistant Secretary for Health, who's graciously come to share some good news with us, I hope. So I'll hand you over to Dr. Koh. Thank you.
So Dr. Snell, thank you very much, and we're going to be thanking you many times for your leadership of this committee through this meeting. So let me be among the first to thank you for your dedication. You told me it's 5 years now serving on this committee and also chairing it for a number of years, so thank you so much. And I'm here again on behalf of the department to thank this group for continuing to address the many, many issues that face us with respect to chronic fatigue syndrome. This is a critical area. It's a challenging area. There are too many patients who are suffering from this, and we need your continued expertise and dedication. So it's very gratifying for me to come here and to see you at this meeting, and we want to thank you for your continued service. I know many of you, but can we just go around the room again and do quick reintroductions? I've met just about all of you, I think, but I just want to be reacclimated. So I know Dr. Snell well, but we'll maybe to his left.
So we start with Dane.
Okay, Dave.
Dane Cook, University of Wisconsin, committee member.
Steve Cratchit, committee member, attorney CM.
Anne's first meeting.
Right.
Lenny Jason, just in time, DePaul University.
Susan Levine, New York City.
Elaine Perry, I'm with CMS.
Terry Michelle with FDA.
And Deborah Willis-Fellinger with HRSA.
Marty Vaughn with the Office on Women's Health.
Nancy Lee, he's my boss.
Charles Wells, Office of Research on Women's Health, NIH.
Hello, Beth Collins-Sharp from AHRQ.
Hermes Balai from CDC.
Nancy Klimas from Miami.
Gayla Marshall from University of Mississippi.
Eileen Halderman, patient advocate.
Jordan Dimitrikov, Harvard Medical School.
Great. Thank you very much, and thank you again for being here. So what I'm very pleased to see is that this is a committee that's addressing all aspects of chronic fatigue syndrome and all the issues around it, issues related to research, education, treatment, quality of life. So thank you for addressing all these in a comprehensive manner, because we need many, many more answers in this critical area. I just wanted to review some of the things that I think the committee has done so well, especially since the last meeting. And let me run through a little list, which I think represents progress and moving forward. You all know that earlier this year, NIH had its first ever State of the Knowledge meeting on chronic fatigue syndrome. I believe it was April. Many of you attended, and a key issue for that meeting was addressing the fact that there are a lack of standards for research in this field. There are differences with respect to study design and sampling methods and patient characteristics assessments, and even a basic definition. And at that key meeting that was opened by Dr. Collins, there was a robust discussion on what should be the so-called minimal data elements for research moving forward. I'm very pleased to hear that a manuscript has now been developed by this committee that summarizes those minimal data elements, and you'll be discussing that at this meeting. It'll allow for better consistency of comparing studies in the literature, which is critically important. I'm a physician and former professor and one who's done many research trials, so I know how important it is to start with some very basic data elements, and I understand Dr. Jason is going to be presenting the outline of that manuscript tomorrow. So thank you very much for that effort. I think that's a step forward that's very, very important for the science of this whole area. And then we want to keep upholding communication with patients and with advocates in the most constructive way. And I know you have a subcommittee on education and patient quality of life that is working with the CDC to provide recommendations to that agency about updating their website to address concerns of advocates and patients and make sure that the communication is going in both directions in a very positive way. So I understand that Dr. Klimas and Eileen Holderman will be unveiling or at least reviewing those recommendations again at this meeting. So thank you to both of you. And then this afternoon, Dr. Marshall, I understand, is leading discussion about interdisciplinary approaches to research here. We need better answers, and we need to take the broadest approach, looking at immune dimensions, metabolic, musculoskeletal, and other components. So this integrated research approach is very key for this field, and Dr. Marshall, thank you very much for taking that on as well. I did want to officially mention to this committee that earlier this year, in the late spring, as I recall, we did have a meeting with the Secretary, and we convened leaders from across Health and Human Services and presented the status of work in CFS and the work of this advisory committee, and also talked at great length about what patients are suffering and what they're going through right now. And so the Secretary wanted to convey her thanks to you. It was a very constructive meeting. She has asked that we coordinate our efforts across HHS more strongly. And as we speak, we are putting together an HHS work group on chronic fatigue syndrome that's going to be led through my office through Dr. Nancy Lee. Dr. Lee, you all know, is our new director of the Office of Women's Health. She's a new designated federal official for this committee. And I'm very, very grateful to her for jumping into this area very quickly in a number of ways. So one way will be to make this work group more cohesive across HHS, report back to the Secretary on an inventory of efforts throughout the department, and do our best to coordinate strategies across the department in a more coherent fashion, and then make that efforts available to people on our CFSAC website. Dr. Lee has, in her opening days, gotten up to speed on the work of this very important committee, and I should also stress, attended the biannual conference of the International Association for Chronic Fatigue Syndrome in Ottawa, Canada, earlier this fall, because she wanted to hear about the scientific developments and the major questions that are before us. And at that meeting, she was able to connect with a broad array of researchers and advocates at that meeting. So I want to thank Nancy for doing that. For those of you who do not know her, she is an outstanding scientist, has a long history in research and science, spent many years at CDC. To have her now be our new Director of Women's Health and to be the designated federal official on this committee, I think is a great step forward, and I want to thank Nancy for taking on that role. And while I'm at it, I also want to thank Marty Bond here to my right, who is the alternate designated federal official and a senior public health advisor to Dr. Lee. So both of them will be liaisons and anchors for you as we move forward in coordinating this very, very important work. Now, in my opening meetings with Dr. Lee and Ms. Bond, we want to continue working closely with you and then especially make the communication with advocates and patients as positive and constructive as possible. So Nancy is already reviewing the CFSAC web page. The office is developing a listserv to reach out to people and increase the communication between women's health and the CFS community. They are working more closely with the Social Security Administration about data exchanges. We are updating the charter for this committee, which expires next year, and the bylaws. So Dr. Lee and her colleagues already started looking into that. One area that we want to advance with the help of our colleagues within the department is to improve communication with non-governmental organizational groups committed to CFS, and particularly looking into the possibility of adding more voices from the NGO community onto this committee. Now that is going to take exploration into the bylaws. There are legal and logistic issues. Clarifying the charter always takes time, but this is an area that Dr. Lee has committed to exploring, and we want to do that because we want these meetings to be as constructive as possible and hear from as many people as possible about how we can work better together. I'm also absolutely delighted that we have hired, or Dr. Lee has hired, Christine Williams as the special advisor. Chris is somebody I've known for a long time. She's got an outstanding reputation in public health. She served as an ex officio member of this committee for a long time on behalf of the Agency for Healthcare Research and Quality. She is someone who has come down with this condition, and she's very open about sharing that in a very constructive and positive way. I believe she testified this morning about what it's like to have this condition. And so Christine is really an ideal person to be a link for all of us because she knows the federal government. She's served in this committee, and as one wrestling with this condition right now, I think she can add multiple perspectives. And so I'm particularly eager to work closely with Christine, Dr. Lee, and Marty Bond as we move forward. So these are all areas where I would like to think that we are taking some steps in the right direction. It's just the beginning, continues to be the beginning because there's still so many unanswered questions. So we're very, very pleased that you are here to keep reviewing these issues and seeing how we can better work together. I want to thank the ex officio members of the committee, and we're going to be working more closely with you and then reporting back to the Secretary on a regular basis about the inventory that we're collecting right now. And then also, as I close, I want to thank the members of the committee who are rotating off in the spring. First, let me mention again the great commitment of Dr. Snell. He's been just wonderful, and working with Chris has been so great. We're going to miss him, and we're going to figure out some way to recruit him back in some other capacity, I'm sure. Dr. Klimas has been a wonderful and productive chair of our Subcommittee for Education and Patient Quality of Life, and so thank you, Nancy, for your service. You've mentioned to me that you spent more years on this committee than off, so we'll probably get you back on somehow as well. And then Dr. Jason, thank you for chairing the Subcommittee on Research. You've served so admirably and given so much of your time and effort. These three wonderful members are serving until the spring meeting, and we also welcome Dr. Ann Vincent, and we're very, very happy to have you here. So it's probably a good time to just give a round of applause to all four of these members and thank them for their service. Thank you very much. Thank you. So those are some comments to share with you. I'm very pleased to stop and take some questions from you, and just thank you again for your dedication and perseverance. These are not easy issues. These are very important issues for public health, though, and we want to thank you for being here and joining with us in a unified way to move forward.
Dr. Jason.
First, Dr. Koh, I want to thank you for coming to the meeting. In the past, we haven't had that type of representation at these meetings, and you have certainly shown by example that you come to these meetings regularly. I also want to thank you for meeting with Dr. Schnell and the other executive committee members to discuss issues between meetings. And that's also something that didn't happen years before. So I want to thank you for that. And I also want to thank you for the excellent people that you've put in place with Wanda stepping down. Nancy, Marty, and of course Christine are excellent. The question I have is that as I cycle off this committee, 4 years ago, as I look around the group, there's only one ex officio member who's still with us who had been there from the start. There's been a certain amount of turnover that has occurred on this committee. Now, understandably, things change within the federal government, but sometimes it takes somebody a year or two to learn the turf, to learn the personalities, to understand kind of how to kind of work cooperatively in the networks that are critical. So I guess the question I have is, how do we deal with the fact that certainly there's a turnover in members, which has to occur every 3 years, but the support staff, as well as ex officio members, also has a certain amount of turnover that makes the consistency and the types of progress that we potentially could make more difficult. And I'm wondering if you might be able to respond to that.
Sure. Well, that's an appropriate question. Well, first of all, we're very grateful to the ex officio members, and I want to thank them again for their commitment. You're absolutely right. We need people who understand this complex area and have some history and some credibility. I would like to think in the last 2.5 years between myself, Dr. Wanda Jones, who, even though she's not the designated federal official anymore, is one of us, if you will. She's in all the briefings. She supplies her very detailed knowledge and continues to be very, very supportive, gives lots of guidance to Dr. Lee and myself, and she'll continue to be involved. She's our principal deputy Assistant Secretary for Health, so she's got a huge portfolio, but she will continue to come to our meetings and give her experience and guidance and obviously her commitment. I think with Dr. Lee's involvement now, you have a outstanding scientist who has already shown her commitment to this area. We've got Ms. Bond here, and it's wonderful to work with her. We've already had a number of meetings as she has come on. Then having Chris Williams also, I think, is just huge. We're just thrilled to have her as a point of continuity. I should also mention that we have briefed the counselors to the Secretary. There are 4 counselors, and they are all familiar now with these issues when they weren't a couple of years ago. And then we had that one excellent meeting with the Secretary, and she wants us to be more integrated across the department, and that's where we are right now. So I'd like to think that with all those forces together, we can give this whole area the integrated, coordinated, departmental approach that it certainly needs and deserves. Thank you.
I was thrilled to hear you have Chris coming back as an advisor. That's going to be fantastic. And I think
everybody loves Chris.
Yeah, Chris really has always brought to the committee a real sense of what could be done using the structure of HHS, which sometimes we, the members that don't understand the government, really don't understand well enough. And it can take literally years to get your feet under you in this committee to understand what can be done and how to work together to bring this forward. Earlier today, Kim McCleary gave testimony saying, look what happened with XMRV and how beautiful the HHS response was. It was aggressive, it was correct, it was fast, and that was an example of how things could happen. And so I think that what I'd like to see is that kind of motivation to go forward without this banner of XMRV to rally under, but still to keep going forward. The patients today, you missed it, gave the public testimony, not everyone's patients, gave a skit today about what happens when you hit the ER and a doctor goes and tries to look up something and sends you immediately off to psychiatry service to get an assessment. And that, unfortunately, was a very real skit. I can't tell you how many hundreds of times I've heard patients tallied off to the psych ER when they hit an ER, or when they come in on 7 psychotropic drugs and there wouldn't be any energy left in the body with the number of drugs a person's been put on to try to, quote, counter those types of approaches. The ignorance of my profession is appalling, just appalling. So if there's one thing that we could do, with motivation, with speed, with let's go out there and get them, it would really be an all-out effort to educate the clinicians on just the first and second line of defense, if you would, the first and second thing to do when you see a patient in crisis or with a chronic illness. And I think, we've talked about it, but we can do it. And the agencies are here that do that thing. Right. And if you could just put the force of the office behind let's just roll out a program. Let's just do it. Let's do it. We're here. We'll help. Anything we can do.
Thank you. No, I'll clap for that too. Thank you. We are trying to put more emphasis into that precise area. I understand that HRSA in particular, is that correct, is working on that area for curriculum and professional education. I don't know if Dr. Lee wants to say more, but you're absolutely right. The lack of awareness and understanding is just too great in this area, and so we need to overcome that, and that's an initial priority for us and Dr. Lee as she moves into her tenure as the designated federal official. Nancy, did you want to say more on that, or?
I think we'll just wait for Deborah, who's going to give an update from HRSA. Is that fair, Deborah? Well, no, I mean during the update time.
Well, I am, though the specific, Don? The specific focus on specific activities to train physicians about chronic fatigue is a very focused area. I can say that we've talked about generically training, generically We have mechanisms in place to share information with communities and with our providers. Now, sharing information specifically about chronic fatigue is not something at this point that I can say that we've committed to. But with your direction, I will definitely take that back. And
that's something that we have a day and a half now to discuss it. So.
Okay, good, great. Maybe one more question before I have to leave.
Steve Kravchik.
Yeah, it's just a comment that one of the most important sources of information for everybody now is the internet. And the websites that are up, whether it's NIH or CDC or whoever, that are talking about chronic fatigue have a profound effect on the reimbursers for insurance and disability. And I think it's important that that get some priority so that the science and what's known about the condition, whether it's post-exertional fatigue or others, is considered as they write it up. And that a case definition is one that it's accepted by IACFS or maybe the Canadian consensus or whatever. But there needs to be some consistency in the information that comes out to help all of the people who are suffering from this, as well as the researchers. Thank you.
Thank you. So that consistency theme, I know, is going to be part of Dr. Jason's overview. Is that right? And then getting that information up and out, put it on our websites, working with CDC and also with the CFSAC website. Those I know are topics for discussion for this meeting. So thank you for raising that.
Well, I'd like to thank you for coming to the meeting,
Dr.
Coe, and I would really urge you to go back and push forward this idea of a concerted effort within Health and Human Services where people are talking to each other about the illness and looking at mechanisms currently in place so that we can really leverage the funding that is available, in these difficult times. And just echoing what Kim said this morning about that huge effort put forward with the XMRV, I think if chronic fatigue syndrome, or whatever we choose to call it, had not occurred up to this point and occurred overnight, and this many million people came down with this unexplained illness, I can't imagine what the push would be to find a cure. And so if maybe we could wipe the slate clean, imagine that whatever's happened up to this point, it is forgotten and just start afresh.
Thank you, Dr. Snell, for your passion and your leadership. I'm just so grateful for all of you. This is not easy. It's a very important public health issue. There are too many people suffering, and we need some answers, but I think we have a group that's so dedicated. I would like to think that with this new team that I unveiled here and some of the progress internally within the department, we can keep moving forward in a unified way. So keep the communication coming. We're just thrilled to have Chris on now as a liaison, and I'm going to be, since we are old friends and colleagues, I'm also going to be eager to catch up with you, Chris, and hear your thoughts about how we can do this better. Thank you very, very much. Thank you.
Weekly memo, Howard. Send out what's happening in CFS to all the agencies.
We're making people wait till 1 o'clock to eat lunch.
So agency updates. I'd like to commend all the agency people for being here, particularly the new people, and nobody's left, so we kind of scared them off yet. The format for these, traditionally is you update us on what's happening relative to chronic fatigue syndrome in your area. If there's nothing happening, let us know there's nothing happening. Try and keep it short, because I know the committee do like to ask some questions. If possible.
So Chris, point of order, are the questions going to come after each presentation, or are the questions going to come after all the presentations? Certainly the questions to me are probably one of the most important issues for our committee as a chance to follow up on issues that are brought up.
So a good point, Lenny. Holding them all till the end makes it a little easier to manage, but it's not so consistent. So if we could try and keep questions, ask questions immediately after the presentation, and I'll try and manage the time. If it looks like it's getting out of hand, I'll call an end to it and move on.
And we, you know, we have a fair amount of time built in the schedule for discussion, and certainly things can be added to that time as well.
And we can circle back around again at the end if we have some time left.
I think we have some flexibility because of the schedule.
Are we going in alphabetical order? Or
well, why don't we do it in the
age?
order on the agenda here?
Which is alphabetical.
There, so it would start here.
Okay, pages. So first up we have AHRQ, which is Beth Collins-Sharp.
Yes, good morning. It's a pleasure to be here at my first meeting, and I'd like to start by acknowledging all of the work that Chris Williams did, including orienting me quite thoroughly to the committee, so I really am looking forward to it. I'm also immensely grateful to Chris and tremendously relieved that she's going to continue to advise all of us, and not just me, so thank you, Chris. I'd like to, when I talk about the agency, I'd like to say the full name so that we can think about what it is that we actually do, and then review just briefly how we might be different from some of the other agencies. So we are the Agency for Health Care, Research, and Quality. And each of those words is important. We're not the agency for health, for example. We're not the agency for just quality. We're not the agency just for research. Each of those words is very descriptive of what we do. We are, in fact, a research agency that focuses on health care, meaning the health services and quality of care, not a particular health condition. So we're interested in the health care surrounding chronic fatigue syndrome, heart disease, cancer, you name it. So our portfolios of work, the things that we focus on, are about health care, not about the particular diseases. So for example, we're interested in patient safety. We have a portfolio on patient-centered care, comparative effectiveness. Health information technology is an area of great interest to us, and the like. As I said, we are a research agency. Our mission does not include setting policy. It does not include making coverage decisions. It does not include generating regulations. It doesn't even include making clinical recommendations. What it is focusing on is research data and evidence that can then directly inform all of those other things. So we will produce and support the generation of evidence that can inform these other decisions. And part of that then is dissemination and translation of that evidence. So for us, translation is not from the bench to the bedside, but from the research bedside to the actual patient bedside. We're interested in what's going to happen in real life. A lot of our work is user-driven, so there are many areas where public can comment, public can recommend topics for us to research, and of course in our grants programs, whenever grants come in, those topics that are of interest to the researchers are the topics that are then reviewed. One grant I wanted to point out to you recently that the findings came out from was one that was mentioned in the previous meeting, and that is Project ECHO, which is a project where health care for individuals with hepatitis C was delivered via health information technology from academic medical centers in New Mexico to individuals in very rural, extremely rural areas in New Mexico. And so this is a great example. It was very successful. The patient outcomes were much improved after this intervention. So this was a good example of a project where a health service, where health care was delivered in a new way, was evaluated and researched systematically. And the disease happened to be hepatitis C. So this is the type, it could have been chronic fatigue syndrome or any other, but they chose that. So this is an example of a very successful research project that was funded through our grant program, and that was published since the most recent meeting. We've talked in the past about our evidence-based centers reports, so I won't go over those again unless you have questions about it. There were two more resources I did want to point out to you, though, as examples of where work comes from others, from the outside in, if you will. And we support the work of 3 clearinghouses. And you're probably most familiar with the National Guideline Clearinghouse. This is a clearinghouse where professional societies, professional groups, practitioners, provider groups can submit clinical guidelines that they've developed, and they must meet certain criteria for quality. The evidence behind them needs to be sound. Then there's an editorial board, and when they're placed on the Guideline Clearinghouse, then it's searchable. There are communities to discuss the clinical guidelines. It helps a great deal with dissemination of the guidelines. And so I went to the NGC, as we call it, and did a search for CFS, and found that there were, in fact, only 5 guidelines that were posted there, that guidelines for clinical care. And of those, only 1 had CFS as the topic area. The others were food allergy, IBS, celiac disease, and hepatitis B, and then somewhere else in the guideline they referenced chronic fatigue syndrome. The one guideline comes from the UK, from the National Health Service there. I mention this because I know that there's been work lately that on clinical guidance for chronic fatigue syndrome, and that there were findings presented at the meeting in Ottawa. And so I would encourage those individuals who are working on that to submit them to the National Guideline Clearinghouse so that they'll be available publicly and to other providers. And then similarly, there is something called the Innovations Exchange, which is another clearinghouse, which is a clearinghouse for innovations. So these are perhaps the things that have worked well in a local setting and aren't quite ready for prime time as a full clinical guideline, but may be some sort of quality tool that you want to share and get feedback with and try to implement it in another place. It's a way to bring people together to discuss these particular tools, innovations in health care. And so I went to the Innovations Exchange, and it's a relatively new exchange. I would say 3 years. I'm sorry, I don't know exactly. But compared to the National Guideline Clearinghouse, it's not quite as old. And so I did a search on Innovations Exchange as well. And there are just 3 quality tools that are listed there. 2 of them come from the Office of Women's Health, and the other is a 2008 VA clinical guideline for unexplained fatigue and pain. So again, I would encourage individuals to contribute to these sites, because there is a lot of traffic to these sites, and it is a wonderful way for us to be able to promote the sharing of information and the exchange of information. And so to that end, I have brought paper bookmarks with the electronic bookmark written on them, and I'll distribute them around here, and I have a number of copies that I'll put out on the table outside. For those who are listening in, all of the the Innovations Exchange and the clearinghouses are all connected together on the same website. Across the top, you can just toggle between them. So the easiest way to get to them is, the simplest address is www.guideline, singular, guideline.gov, guideline.gov, and that will take you to any of the clearinghouses or exchange that you might want to visit. So thank you very much.
Thank you, Beth. Dr. Jason has a question.
Thank you very much. I want to applaud your brief presentation, as well as very information that's so relevant to our group, which I think sometimes has not happened. A couple very quick questions. One is Project ECHO for hepatitis C. That was a really interesting project. Is it possible for something like that to occur in this area, given that there's thousands of people in rural areas who probably could benefit from some similar types of demonstration projects, and what would be the mechanism for getting that thing to occur? The second question is, there is a group, several of people, members of this advisory group, are developing a healthcare primer that's been being worked on for the last year and a half. I'm just kind of wondering, are there any efforts of solicitations from your group to reach out to groups to provide them funding to help actualize and finalize and finish these types of products? Or do groups external to your agency come to you with finished products? So the question is, are there inchoate types of situations where there's such a pressing need for materials that your group solicits or tries to work collaboratively with those groups with some potential resources to make these complicated endeavors implemented? Thank you.
So to the question on Project ECHO, that was a grant mechanism, and given that it was so successful, there are a number of individuals who are interested in Project ECHO for a variety of conditions and areas of interest. I can't guarantee that there would be any sort of Project ECHO CFS, but CFS, sorry, I tend to reverse the letters. But certainly a successful project that is implemented in other areas is of interest to the agency for potential funding and grant funding. So that because it's been funded before in a different health condition does not dissuade the agency from considering it being replicated in another area. But because it was successful, I would also refer you to the investigators themselves, because they also have thought about spreading this to other areas. And they have a number of other topic areas, as well as expanding it into other sites. And so their website is easy to find, and there might be some interesting, helpful information there as well. Your second question about funding the healthcare primer, traditionally, individuals come to us first rather than us having a direct solicitation. That doesn't mean that it might not fit under one of our requests for proposals. Yes.
Susan?
Hi, Sue Levine. No, I had, okay. I know you said, you referred to the authors of the Project ECHO project, but in general, if someone were to submit a grant proposal to you, would you have had to research the epidemiology of that condition in the area that you're interested in? Say for CFS in some rural area of New York, would you want to know the approximate prevalence of the illness? Would it be a more compelling request for funding if there was a higher population affected?
One of the priority or decision-making considerations on all grants is burden of disease. And burden of disease does not necessarily mean prevalence. So the burden on individual, for example, certainly burden of disease in this case is obvious. It would need to be detailed, described in the grant to those who may not find it obvious. But burden of disease does not necessarily mean high prevalence. It's helpful, however, to have those data when you can find them.
Beth, just a couple of follow-up questions. So these are unsolicited proposals. Is there a format for these?
The agency follows the NIH formats and, in fact, use the electronic submission program, all the same as NIH. We have our own review panels and peer review process. But the format is exactly the same as an NIH grant.
And that information is available on your website?
Yes, indeed.
And just to be realistic, in this day and age, is the money available, or are we just wasting our time writing the proposal? I'll take that as a no.
No, I don't want to discourage you at all. Strong proposals are important to us, and it's hard to predict from one funding cycle to the next how it's going to be. So I try not to, I encourage folks personally when I talk to grantees or potential grantees not to try and play a timing game or a funding game, trying to predict where the money stream is going to be and when it's going to come. The science, the strength of the science needs to come first. So if it's a strong study, that's what we need to concentrate on first. It is financially constrained times, but we want to continue to move the strong science projects forward.
Thank you, Beth. Lenny has a follow-up question.
Lenny, Jason, follow-up question. Sometimes agencies have kind of priorities as to the things that they are most interested in. I was wondering where CFS kind of might fit in with the long list of potential issues, because you did say you're not disease specific. And is there any way that this particular group could make a recommendation to your agency that potentially could be helpful, that could bring up this area to a higher priority that might be considered for funding?
Realistically, our mission is so completely entrenched in health care, health services, that having a particular condition called out is just not a thing that's going to happen. And it's not going to happen for heart disease or cancer either. I mean, there are priority areas that include some disease conditions, but again, it goes all back to burden. Patient care burden. So I'm sorry, I can't think of.
So just a quick follow-up. How did it happen with hepatitis C, which is a very specific illness?
So that was chosen by the researcher as the test case, if you will, for this health service delivery process. Does that make sense? Yes.
Nancy.
I know that some years ago, AHRQ sponsored or did an evidence review on chronic fatigue syndrome. So that was what, 10? When was that? 10 years ago-ish? What is that process? Is that something that is needed? Is it something that we as a group here should push for, that me in my new role as convening the HHS, I'm not sure what we're going to be calling that other group, but should be pushing for?
So that was, I brought the executive summary as a reminder because I'm not very good at remembering dates. That was published in December 2002, and it was a systematic review related to disability and chronic fatigue syndrome. The Evidence-Based Practice Center, or EPC, reports are systematic reviews of the evidence on a particular topic, and the topics are nominated by individuals, groups, I should say groups, but it might be at patient groups, it can be professional groups, it can be clinician groups, it can be government agencies who have a decision that needs to be informed by evidence. And so these topics are nominated by someone else. So, for example, this particular report, which was done in 2002 or the end of 2002, was requested by the Social Security Administration to inform their decision-making in a particular area related to the disability associated with chronic fatigue syndrome. If the federal agency requests the report, they also fund it. If you're not a government agency and you're interested in if you have a particular decision that you're interested in making and you need evidence to support that, if you're developing a clinical guideline, for example, that's the most common use of these reports. A professional society wants to develop a clinical guideline on X. They will nominate the topic and do a write-up that explains why this is important to them, why there is sufficient burden of disease and clinical need, and how they will use it. The agency is not interested in producing reports just for the sake of producing a report. They actually want it to be used. And so we want to know about that from the get-go. If there are individuals who are listening or watching and are interested in nominating topics from a non-government perspective, you may do so online via the Effective Healthcare Program, and that is www.effectivehealthcare, all one word, .arc.gov, effectivehealthcare.arc.gov. You can get there from our AHRQ webpage as well. It then goes through a prioritization process, and then if it's selected, then there's an evidence review generated. There was one other piece about that I wanted to mention.
Who pays for those?
AHRQ pays for those.
And how much do they cost? Do you know?
Give or take, this is the million-dollar question, but it doesn't cost $1 million. About half, so about $500,000 for a systematic review of the literature, give or take.
Quickly, Lenny, otherwise we won't have time for the other.
That 2002 report, which I've seen, is really pretty outdated at this point. Is there any possibility of that being updated? And if that were to occur, how might the process sort of start to do we have to find kind of an ex officio member at this table who goes back to their agency and requests it? Could the CFSAC be the group that basically requests it? What's the process for taking the next step?
So updates are handled in exactly the same way. If an update can come from an update request can come from a federal agency who then would bring the money with them, or it can come from outside. You can make a request for an update. The request for the update can come from a different nominator than the original report. So a request for an update would not necessarily have to come from Social Security Administration. If it was a government agency, though, they would come with the funding.
Could it come from CFSAC?
I'm not aware that CFSAC has a funding.
No funding.
Just hold that thought until SSA give their report tomorrow, and we may just mention that they're due a refresh. So, next we have CMS, Elaine Perry.
Sorry.
Thank you.
Thank you. Yes, Elaine Perry, and I'm with CMS, which is the Center for Medicare and Medicaid Services. This agency has been participating in CFSAC for about a year now, and I've been the ex officio representative during that time. And I just wanted to say first that I've really appreciated being able to participate in this and to learn from the committee, and especially from the members of the public who have given their testimony. And I just really appreciate the effort people have made this morning and during other meetings to do that. So I just wanted to mention that. What I want to do is just give a very brief overview and kind of refresher about what our agency does for those who might not be that familiar with it, and then talk about progress on some of the specific requests that the committee made at our last meeting. So then just briefly, CMS runs the Medicare program and also runs the federal portion of the Medicaid and Children's Health Insurance programs, which are joint federal-state programs. We also have well, actually I should mention, for those of you who like facts and figures, I brought some handy wallet cards and little booklets. I didn't bring enough for everybody because I didn't think you all wanted, everyone would want one, but if anyone wants to carry around data about our number of beneficiaries and various data points around with them everywhere they go, I do that, so we do have those available for you. And the new function that we gained in the beginning of 2011 was that the Affordable Care Act had a whole portion that addressed the private insurance market, and we became responsible for implementation and administration of the federal portions of that. So we have new functions that basically we oversee compliance with new insurance market rules, things like the ban on annual dollar limits. We are helping the states review premium increases and overseeing the new medical loss ratio rules. We administer, along with some state involvement, also the Consumer Assistance Program, the Early Retiree Reinsurance Program, and also the Pre-Existing Condition Insurance Plan, or PCIP. And I wanted to specifically mention that because Eileen had raised some questions earlier in the year about, and raised some concerns about insurance coverage for people with CFS, and just wanted to point out that this pre-existing condition insurance plan is a new insurance option that is available. And another very important function that came out of the Affordable Care Act that we perform is the development and continuing development and oversight of the new website, www.healthcare.gov, and also wanted to point this out as a possible resource for the committee and for members of the audience, people listening. This is a website with the goal of providing very clear, understandable information to the American public about health insurance options that may be available to them, both under the new legislation and already existing options. And, you know, I've been to it and tried it. I recommend that you check it out. It's very user-friendly, and you can go and put in information about yourself, the state you live in, and, whether or not you're low income, and something about your, whether you have a chronic illness or a disability, and then you can get information about different options that you could explore, and links to state resources for those options, including the pre-existing condition insurance plan. So I just wanted to point that out as a resource. And then, of course, we're also involved in the federal portion of the state-based health insurance exchanges, which will be up and running in 2014. Okay, so that's covering what our agency does. And then as far as the requests from the last meeting, one of the things that you had talked about the last meeting was an idea of having, it was just discussed in the AHRQ update, a virtual learning network focused around CFS that would link researchers and expert clinicians and clinicians who wanted to learn more about how to care for patients with this condition. And you had asked me to get some more information about whether how the CMS Innovation Center might possibly be able to play a role in supporting a network like that, or being one of the supporters for a network like that. Just to sort of recap, the Innovation Center is a new center within CMS whose charge is to test innovations in healthcare service delivery in Medicare and Medicaid, but also innovations that could potentially be spread more broadly beyond just Medicare and Medicaid. And it has authorization and funding to test innovations, and will be doing so over the next 10-year period. They have about a month ago, I think, I sent the committee a link to their website because I thought that would probably be the best way of really giving you the, from the horse's mouth, the virtual horse's mouth, I guess, the information about what their process is, what their criteria is for choosing what type of innovations they want to fund. And so you guys should all have that. And they actually give some pretty detailed instructions about their process. Basically, what they are doing at this stage is soliciting not proposals per se, but ideas, so more general ideas for types of projects for which they then might choose to then develop further and actually, potentially put out an RFA or put out a solicitation for proposals, but they're actually not. This process is not a formal solicitation. It's really just attempting to get input from different groups, whether it's providers, patient groups, and any members of the public who would like to weigh in. So I'd be happy to take any questions about that process, but I probably will have to take them back and get answers for you from the agency because I wouldn't want to wing that. So that's that. The other thing that was handed out to you just a few minutes ago is a preliminary response, at least, to some of the requests for data that you had made. So you should have that. There were 2 sheets that everybody should have gotten. And this is in response to questions that both Lenny and Eileen had raised about Medicare and Medicaid spending on individuals with CFS. And so this is very partial, and that's for a couple reasons. One, there's some things that are just harder to get and are going to be more challenging to get, and then there's some data that just is not going to be available or is not going to be accessible currently. It might be available somewhere within federal databases, but not something that we have ready access to at this time. But I don't want to take too long, but I just want to kind of give you a little bit of guidance about what is in these documents. Basically, what this represents is Medicare spending only. There's no Medicaid information at all on here. And it's Medicare spending for Parts A and B, which is the traditional fee-for-service Medicare for hospitals, physician care, outpatient care, that kind of thing. So it doesn't include prescription drugs, which are Part D, and it doesn't include Medicare Advantage plans, which are where people are not under the traditional fee-for-service system. They join a plan, and their care is provided through that health care plan that they join. So this is Part A and B data, and what it gives is 2 things, basically total spending under Part A and Part B, and then also the total counts of the number of individuals. And there are 2 different sheets because what I did is what we usually provide to get a count would be to look solely at the primary diagnosis. So the sheet that says for principal diagnosis code 7871, chronic fatigue syndrome, that basically represents everyone on Medicare Part A and B in 2010 who had any claim under Part A and B where CFS was coded as the principal diagnosis in the first, coding slot. But then because I wasn't sure whether this is always going to be coded as the principal diagnosis, I also asked for them to run the same data on people with that diagnosis in any position on the claim, so it could be second, third, whatever. And you can see that there are considerably more people represented when you use that method, about 300,000 as opposed to about 100,000 with the principal diagnosis. And this is for calendar year 2010 only. And one thing I wanted to make clear when this gives total expenditures, these are expenditures for all claims for those individuals. So they could be claims for anything. Someone could break their arm and go in for treatment for their broken arm. Those costs would be represented in here. It's not necessarily claims just for CFS treatment. The other thing that it's not is necessarily
just individuals who were determined to be disabled by CFS and got on Medicare for that reason. This is anyone who had a visit to a provider and was coded as having that diagnosis in the visit. So they could be on Medicare because they're 67 and they're eligible due to age, for example. And this actually does break down the individuals by age groups and also by the reason for entitlement. So whether they're on due to, the major categories being they're on due to age or they're on due to disability. ESDR is end-stage renal disease, and those are very small categories. So I'd be happy to take any questions, and I don't necessarily see this as the final answer to your request, but I wanted to give you something as a starting point, and we can continue to talk more about what you think, information you think would be helpful.
Thank you, Ian. Lenny, then Susan.
First, I want to thank you. I mean, we made a request. You came back with incredible information. I've been looking for this information for probably 10 years because I've been particularly interested in the economics of this illness. So just a hearty thank you. And we will have other requests that we will make of you. But more specifically, the Innovation Center, I mean, that really sounds, again, like a wonderful opportunity. I want to thank you for sending the link to us so that we could see it. The question I have for you is that, I mean, if there was a solicitation of a particular area for funding of RFAs in the future, which is possible, would it be better for individuals here to make individual requests to your agency or to the Innovation Center, or could the CFSAC, as a group, make a recommendation to you that this particular area is so understudied, underfunded, that we think this could be a priority area for your agency? Which is the best way of giving feedback to the innovation group?
You're talking about, it wasn't clear, you're talking about giving feedback now or giving feedback in the event that an RFA were issued?
I guess you're looking for feedback to help set the agenda.
Correct.
And as you set the agenda, we can give you input. So the question is it better for us to be giving individual input as individual members, or can an advisory committee give input, and would that carry any more weight?
At this stage with the process for submitting ideas, I think either. You know, I can't say for sure how they would assess, you know, who it comes from. I think they talk on the website about some of the criteria, and their mission is to find in the statute, is to find ways to hopefully both improve healthcare quality and reduce costs at the same time, or to reduce costs without reducing quality. So they're looking at innovations that will do those things. So I think that's going to be the lens through which they look at something, whether it can make healthcare more efficient and effective, and whether it would be applicable to different, you know, more broadly across, you know, whether different groups or across different types of payers. So those are just some things to think about that are on their criteria, but they give a more detailed explanation on the website.
Hi. Yeah, I also applaud your quick response to this, but I need help in figuring out what it's. Now, which state does this data apply to, or is it nationwide?
This is national. It's all Medicare data, and Medicare is a national program. This is all national data.
Okay. And so, if you don't mind, can you run me through with chronic fatigue syndrome as the main reason for entitlement? Where do you see the highest number of patients? I mean, in what grouping would it be then? For instance, age 31 to 64 would be the most visits?
Well, I just want to be looking at the same one you're looking at. Okay, we're looking at the one where it's CFS at any location on the diagnosis code trailer in the heading. So that's the one that has the higher figures because it's not just principal diagnosis.
there are two tables. One is is listed as the original reason for entitlement, and one is the current reason for entitlement. And that's not necessarily hugely important in this case. The distinction I don't think is necessarily tremendously important here, but what that means is the most common case would be that someone initially was entitled to Medicare because they were disabled. They were determined by the Social Security Administration as being eligible for Social Security disability benefits, and they got entitled to Medicare through that process. And then as they aged, they turned 65 and they were converted. So they could be, have the same disability, but now they're considered to be on due to age rather than disability. That's just the way they're categorized in the data. So I was kind of interested to look at these numbers and see that by far the most people are within the aged category, over 65, which was kind of a surprise at first, but then I realized, well, it's probably because most of the people on Medicare are in the aged category, so it really represents the structure of the program.
Well, also, does it represent necessarily, or is it possible to find out if it's one provider? Let's say a patient with CFS visits an ER doctor who doesn't really know about CFS. Would that be lost to this, in other words?
Right. If a person could have CFS and even have been determined eligible for Social Security and then Medicare because of their CFS, but it could be that in 2010, they didn't visit a provider who put down this particular diagnosis code on the claim. If that's the case, they won't be in here.
I think it'd be interesting to know, like, the uniformity of provider per diagnosis, or if there are more than one provider per patient that wrote CFS as the primary diagnosis. That'd be interesting to see that kind of data.
Yeah, I'm not sure whether I could look into that. I'm not sure whether that would be available.
Because it would give us a clue, I think, as a committee, the familiarity of other providers and across the country with the diagnosis.
So the question is, to what extent they are receiving the same diagnosis code from multiple providers within that year.
Right. And there's a large difference among different areas of the country, different pockets, and
yeah, that would get into a lot of detail, but I could
target educational efforts in those areas.
I'm Chris.
Eileen.
Yeah. First of all, Elaine, thank you so much, because I know I loaded you down with a lot of questions. It was huge. I wasn't aware that CMS oversaw the Affordable Care Act, did you say?
Well, not the whole thing, but certain portions of it that have to do with private health insurance. Our agency is now responsible for administering the federal portion of those, and that's a new responsibility that we were given by HHS in early 2011.
Okay, and a couple of things that I mentioned in one of my memos was the Affordable Care Act, the PCIP program, and the pre-existing condition for adults. And I want to say that I just read an article about it, and I'll get it to you. It's not really being promoted. A lot of Americans don't know about it, and they have a very low attendance, applicants for it. So I'd like to know first, who's responsible for getting the message out about that, number one. Number two, it's under the Affordable Care Act, but it turns out not to be very affordable. This insurance is pretty pricey, and what can be done about that? And third, it also has a requirement that you have to be uninsured for 6 months. And this is, for someone who's disabled, can be catastrophic. So it doesn't sound like the Affordable Care Act has gone far enough, and what can be done about that. And in a related question, with Social Security Administration, if you have CFS and you relinquish your entitlement to Medicare because you have other means to pay for health insurance, and at some point down the line, if you decide you want it, SSA and Medicare makes you wait 6 months to be uninsured, where you are getting sicker, racking up bills, all because you forfeited Medicare at that point. And you would think that that would have been a good thing because you're not utilizing a government entitlement so that someone else could, and you're trying to buy insurance on your own, and yet you get penalized by waiting 6 months. And not only that, then they slap on all kinds of heavy penalties about your premiums. It could cost you 2-3 times higher. People think they hear the word entitlement. Medicare is expensive and it's complicated, and I'm glad we have it, but it's not what I think the general public thinks it is. So those are some of my issues with it. I don't know where you want to begin.
Okay. Well, I definitely, I can take back some of the concerns you mentioned about, particularly about the outreach. I assume, I'm not sure, I assume that that's a joint federal state function because that program is, the PCIP program is joint federal state, but I can take back that concern. Some of the things that you mentioned around the different enrollment periods and the different requirements, some of those may be statutory. So I'm not quite sure what is in the law that passed by Congress and what is under CMS's discretion. But I think some of the things you mentioned are probably in the statute and things that we can't change, that it would require a change in the law from Congress. But I can definitely take back your recommendations and also try to get some, maybe by tomorrow, or if not, follow up and get you some more information about these issues.
Thank you, Elaine. You've been
Thank
very
you, Elaine.
conscientious. I'm going to move on, Nancy,
you
because
did
we're running
great.
out of time. So.
This was an extraordinary effort. It really puts things in perspective. And it's very important to realize that less than 20% of chronic fatigue syndrome patients are diagnosed and carry a code. Okay, so when you're looking at this, this is the 20% that are diagnosed of the 20% that go on to have a Medicare access either by age or disability, and the government spending more than $100 million a year in Medicare reimbursements in that very small subgroup. So if we could please put that all in perspective when we're spending $6 million a year in research. It's extremely, the math just boggles the mind. It's very important to see how these numbers, to me, they're just staggering. And I really appreciate your hard work at putting that down because it gives us a perspective.
Thank you.
So we have another new ex officio, Teresa Michelle from FDA. Thank you.
Thank you. It's a pleasure to be here today. So as you heard at the last meeting, and also as part of the public testimony this morning, on January 16th, the Office of New Drugs announced that all of the new applications for ME/CFS treatment, regardless of the proposed mechanism of action or regardless of the primary endpoint, will be assigned to the Division of Pulmonary, Allergy, and Rheumatology Products. This includes NDAs, which are new drug applications or marketing applications for small molecules, BLAs, or biologics licensing applications, which are marketing applications for biologic products, and INDs, or investigational new drug applications, which are the applications that allow investigational products to be studied in humans. And that also includes products that are already on the market for other indications that now there's a desire to study them in chronic fatigue syndrome. I'm pleased to report that the transfer of applications is now complete. And as part of this transfer, I've transitioned as the FDA ex officio member of the committee, replacing my colleague, Dr. Mark Cavell-Cole, who I'd like to recognize for his many years of service to this committee. And we're also in the process of determining an alternate should I be unable to attend for any reason. So we'll get back to you on that. One of the goals of this transfer is to allow development of expertise on ME/CFS within the division. And we've begun a process to begin to educate our cross-disciplinary reviewers on ME/CFS. Another goal of the transfer is to give sponsors and investigators sort of a one-stop shopping for ME/CSF applications. In other words, a medical home for these applications. And I just want to say that the division very much welcomes dialogue in the form of pre-IND meetings if anyone is considering human trials, and that applies both to individual investigators as well as drug company sponsors. If you'd like to request such a meeting, there's a formal process for doing so, and you can send a request to Ms. Sandra Barnes in our division. And finally, this consolidation allows the division to work towards facilitating development of endpoints for trials in ME/CSF in collaboration with the study endpoints and labeling development team. So there are new development pathways available at the FDA for qualification of clinical trials outcome assessments. And these are entirely new processes that didn't exist just a few years ago that allow qualification outside of a traditional drug development pathway. And additional information on these processes are available on the FDA website, and I'm going to give you a long, complicated website address. But if you wish to have this specifically, it will be in the minutes, or I can provide it after the meeting. So that's www.fda.gov/downloads/drugs/guidance compliance regulatory information /guidances/UCM 230-597.pdf. So like I said, if you want access to these specific guidances, see me after the meeting or check in the minutes, and this website will be available. Thank you all.
Thank you. Any questions for Teresa, Lee?
I don't know if this is confidential information or not, but is it possible to get information about how many ME/CFS drugs are currently being reviewed in any capacity? And if that information were to be available, could that be something you could be updating us at our regular meetings about actually how many kind of things are actually going on in your area concerning this particular illness?
Right, that's a very good question. Under law, I'm not permitted to discuss anything about a particular application or even give you, general information about applications, be they drugs that are under investigation or even drugs that are approved. Now, once a drug does get approved, the approval of that product and the entire review process is available on the website. Currently, you don't even have to go under Freedom of Information to get it. It just shows up there for all new approvals. Now, if a product is not approved, we're not allowed to say a word about it. So there's a lot of desire to change that under the auspices of trying to be more transparent in government, but under current law, I'm not allowed to do that. Now, whether or not I could provide aggregate information, I suspect that I can't, but I will look into that and report back to the committee as to whether or not that's permitted, and if so, what numbers I could give you.
Susan?
I just have a quick question about this new drug that we heard about from Norway. Let's say an investigator wants to try it, theoretically wants to try this medication on one very ill CFS patient, is there a mechanism in place for getting compassionate drug approval for a CFS patient? And how realistic is that?
So a physician, as you know, can, for an individual patient, prescribe any drug that's on the market for any patient for any reason. If you wish to do a clinical trial of said product, then that would fall under the IND regulations. And what you do is you submit an IND, an investigational new drug application, which contains chemistry information about the drug. In other words, where are you getting it, whatever's known about how it's manufactured and so forth. If it's a product on the market, you know, supplying the package insert and so forth, and the manufacturer is generally sufficient. Whatever toxicology information is known about the product and literature references are acceptable. And finally, what your protocol is. And that's the most important part, to make sure that whatever you're doing has enough belts and suspenders on it to make sure that the safety of the patients is taken into account in your clinical trial. And that's really the entire purpose of the IND process, is to assure the safety of patients in clinical trials. So for an IND to be approved, you don't really have to show that your drug works. All you have to do is show that your drug would be safe for investigation.
I'm going to, with Deborah's gracious permission, I'm going to postpone HRSA until later, because it's getting close to lunch. And I just did want to ask Teresa one question. I noticed on the website that there's quite a lot of information about acceptable outcome measures for trials. What is the process for determining what are acceptable outcome measures for trials involving chronic fatigue syndrome?
Good question. That could be an all-day discussion, but I'll try to give a thumbnail sketch. So right now, we don't really know what an acceptable outcome measurement would be, because we don't have any drugs approved. And so as such, the regulatory pathway for approval has yet to be determined. What I would encourage sponsors to do if they're near to approval would be to come, talk to us about it. There are processes for sponsors to request meetings. I'd also encourage you, if you're interested in developing a new outcome measurement, to put it through the qualification process that I was mentioning. And I think this is really quite exciting, because prior to this point in time, the only way that a new clinical outcomes assessment could be put into play, so to speak, is through a drug development process. So you had to have a drug in order to get an outcome measures approved. Now we have a process by which non-drug companies can come forward with outcome measures and walk them through a qualification process. So I think that's very exciting and will help push the innovation, which is why it's part of our critical pathway.
Thank you, Teresa. 1 minute, Steve. Last question.
Yeah, a couple things. Lyrica and Cymbalta have been approved for fibromyalgia. Would they have gone through this same group, the rheumatology group?
Yes.
Okay. What kind of outcome measures were used for those? And don't you have to at least beat placebo?
In general, in order to get approval, you have to show that your product is better than either placebo or better than whatever's on the market in clinical trials. And the regulatory language that's approved under law is very specific about the evidence base that's required for approval. So it's generally 2 phase 3 reproducible trials. Now, Lyrica and Cymbalta were approved for pain specifically. Right. And prior to 2 years ago now, the rheumatology group was under the pain area. And those drugs, since they're still approved for pain, fall under the division of anesthesia and pain products, rather than under our division.
So rheumatology was taken out of the pain group and put in the lung and allergy group?
That's right.
But the drugs didn't follow them there?
Well, those drugs were in that division, but they were looked at by the pain part of the division because the endpoint was pain.
Got it. Thank you.
Lunch will reconvene promptly at 2 o'clock. I believe we're in the Jupiter room.
Where the coffee was?
Thank you.
Thank you.